Well, thank you for coming in today on Saturday morning. And just to let everybody know, this is our 5th CV Symposium. And that is basically just to make sure that our nursing staff and doctors, they are on the best practices. And we have been keeping up with the new changes and guidelines and so on and so forth. But with your hard work, with your dedication, we would have never ever gotten better from a small farm hospital to now 2 campuses, which have more than 500 beds. And the cardiovascular care is best in the state actually. Although they are big giants like Mayo Clinic and Banner, nothing against them, but we are clearly better than them in many ways. That is all because of your support, your dedication, and the help of administration, that they value these things. They value education, and that's why we are here today. And so with that, I welcome you guys, and we will start our the symposium for this year, and we'll continue to move on every year. And as you can see, there's a big presence of Zoom, which we learned from COVID. So we did it until 2019, and then the COVID came, and so that's the rest is history. So I requested Jeff McBee, who is the CEO here at both campuses, and he has been kind enough to leave his football game, and he's here with us. Jeff, would you please come?
For the record, I haven't left my football game. I will scramble to Peoria after this for my 4-year-old grandson's first soccer game, so I will make it.
Thank you.
Thank you, Dr. Shakur. So first off, looking at these slideshow, I know I think going back, we had our first symposium back in 2016. We actually haven't had one since the pandemic. I'm looking, there were a couple of pictures of me up there and thinking, wow, my hair has turned gray. So a quick reflection, teamwork is the ability to work together toward a common vision, the ability to direct individual accomplishments towards organizational objectives. It is the fuel that allows common people to attain uncommon results. And that's Andrew Carnegie. And as Dr. Shakur mentioned, we have built really not just an amazing cardiac program across the East Valley, but just amazing services. I was showing a couple folks an image from our first neurointerventional case over at Chandler last Friday that Dr. Ducray did. I'm thinking how much work we put into getting that program up and running. I remember when I first came here, I think May of 2015, we had our first ECMO meeting, and now we've got that up and running, and we've exceeded our expectations, not just in terms of volume, but our mortality rate there. I mean, everything we do in East Valley, we do exceptionally well, and that's because of our staff, our leadership, our physicians, the dedication, and just the focus and the quality that you provide is amazing. I do want to thank Dr. Shakur for the work that he's done, not just for the symposium. He chairs our educational committee. He's always looking for opportunities to go out and educate. We've got doctors available, cardiologists, CV surgeons. If you have a need in your areas and you'll dedicate the time, we will get folks out there to educate and build a curriculum around whatever you want us to do. Also, and I'm getting the red from Mel. I said I was only going to speak a couple minutes. I want to thank Cheryl Hasper and her educational team. I want to thank all the folks who volunteered their time into this, and thank all of our presenters and all of you for attending. This is amazing, so thank you for coming.
So since we're talking about this, our team, the education team, which is behind the scenes, they have worked tirelessly. They were here all day putting these tablecloths and so on. I would like to recognize Cheryl Hasper, Judy Bach, Cody. Where is Cody?
Yeah.
All right. Jessica Matthews, Melody, our best Melody, and Brittany Gomez from St. Joe's. So with that, I'll start with the first speaker. That is Dr. Badi Marmouche. So this is Dr. Straw is standing next to me, and Dr. Deep, we are the education co-directors. We direct the education committees. And I wanted to say that Jeff was talking about gray hair, and some people have no hair. So that's what time does to you. But luckily, we have some very good supply line of new and bright young doctors. Dr. Fadi Marmoush is a bright young budding or almost grown interventional cardiologist. He has done amazing work in the cath lab. So he has agreed to share his knowledge about ACS and SEMI and non-SEMI. Again, there are notebooks on the table. If there are questions you have and you're a little bit shy, please write it on the paper and give it to us. And we have some cath lab staff as well, and I want to thank them for taking out the time to come by. All right, it's all yours.
Great, thank you. So I like history. So the first time anyone described acute myocardial infarction was James Herrick's in 1912. There was a paper that he described how patients with acute myocardial infarction presents. And since the evolution of cardiovascular care for patients that come with acute myocardial infarction has evolved significantly, of course. It has gone through different phases. In my personal opinion, it's a success story that is, probably not less important than the invention of penicillin for such a very important and one of the number one causes for death worldwide. So we've been through different phases. Phase one in 1912 to 1961, where the patient comes in with acute myocardial infarction, and we just admit them and watch them. Nothing else. Maybe give them some aspirin. Expected treatment, they call it. And then from the 1961 to the 1974, at that time, the evolution of coronary angiography, general technology, has started to happen. Bypass surgery was available around this time, but it wasn't really for acute myocardial infarction. It was too much surgery to bypass then. But during that time, 1961 to 1974, we had coronary care units emerging. And beginning of the 1970s onwards, we started what we call the reperfusion era, meaning like we're not going to just wait until this myocardial infarction goes on and takes its course and cause whatever damage or complication. We're actually going to try to open this area and reperfuse the myocardium again. Of course, we had lytics and still around. I personally practice in remote cities like Globe and even further to the east in the reservation at San Carlos. And this is the only thing that is still available everywhere, in every hospital, in every ER. That started to establish around the 1980s when patients will come with acute myocardial infarction, they get thrombolytics. And then in the early 1990s, we started to have balloon angioplasty. I mean, stent was, technology was still in the beginning. And that has evolved until we got multiple generations of stent now. So it's a very interesting success story. I just came across interesting quotes here. So let's start with this one here. This is James Herrick description of what an acute myocardial infarction looks like. And he basically done autopsies on these patients from thrombus, occluded vessels. At that time, they were not sure if this is because this is the cause of death or the cause of acute myocardial infarction. It just happened. They happened to see thrombus on autopsy after postmortem. He described it as wounds of the heart, and cardiac rupture was feared as a dreaded, invariably fatal complication. Patients will stay in the hospital for several days, bed rest 2 to 3 weeks, and the usual duration of hospitalization will even extend sometimes to 6 weeks. Basically, they were doing nothing but just watching the patients. I find this interesting, so I'm going to read from the middle here. So in the first book, devoted entirely to this condition, emphasized the frequency and danger of cardiac arrhythmias, and recommended quinidine for ventricular tachycardia, intramuscular adrenaline for AV blocks. EKG was not available, so he suggested that the nurses be trained to detect arrhythmias by frequent auscultation. So it was tough to be a nurse in the 1920s, for sure. So since the 1970s, basically with the the beginning of the reperfusion era, we started to see a massive decline here in fatality in terms of acute myocardial infarction. Makes sense. So let's start with the pathophysiology, because I believe if you understand the pathophysiology, a lot of the things we do on a daily basis, we take for granted. Someone come with, let's say, an STEMI, we start with heparin grab, someone comes in with STEMI, they take it from the ER to the cath lab. Everything is for a reason. So coronary artery disease, atherosclerosis, it's a process of plaque building inside the vessel. I mean, eventually you get a narrow lumen and less blood flow. When we talk acute coronary syndrome, we're talking about disruption of the integrity of this plaque. So as long as the content of this plaque is kept inside behind this thin cap over here, you're not dealing with an acute coronary syndrome. You're dealing with whatever symptoms the patient has. The patient could be asymptomatic. The patient could be having symptoms when they exert themselves or post-stable angina. And a lot of times you won't know about it unless you look at it. But once you have acute coronary syndrome, that's the beginning of the destruction of the integrity of this plaque. The content of this plaque gets exposed to the blood flow, and the bloodstream reaction. We have hemostasis mechanisms, and this is certainly to prevent bleeding. But the bloodstream reaction to it is that this hole needs to be plugged in, and then starts to aggregate platelets, and platelets start to invite start a cascade of events for coagulation, and you end up with a clot. The clot blocks the blood vessel further, and that's when you get the myocardial infarction. So this is very important distinction between what a coronary artery disease in a stable manner looks like and what acute coronary syndrome is. So basically, to the same point, the definition of myocardial infarction. So to say that someone is having acute myocardial infarction, you have to have cardiac cell necrosis. Like heart muscle cell has to die for it to be considered a myocardial infarction. Anything other than that, it's not myocardial infarction. Of course, we have unstable angina as the first thing, or the most mild form of acute coronary syndrome in the very beginning of the spectrum. But it can evolve over to myocardial infarction, or the patient can go straight to myocardial infarction. You don't have to go through, all the steps. You don't have to have unstable angina first and have acute myocardial infarction. Our nurses here in the cath lab, we see a lot of oftentimes patients in their 40s, 50s, healthy. They happen to have a plaque rupture of a blockage of, let's say, 30, 40%. That if you do a stress test, you won't find it. So it's an event. And that leads to myocardial ischemia and therefore cardiac cell necrosis. So the story is very important, of course. It's not often that obvious, especially in women. They don't typically have the typical symptoms as men do. But certainly the most classic type of symptoms is chest pain that is central, retrosternal, goes to the left arm, goes to the jaw. But it could happen on the right side too. It could be it can be epigastric, it can be a back pain only, it can be a jaw pain, and then the constellation of other symptoms that are very non-specific. They could be anything else. And this has a very important, implication because, a lot of times we diagnose STEMI on EKGs, and we've seen before patients come in through the ER, they come with very vague symptoms. They are not recognized as myocardial infarction. And then they get the EKG, let's say 15, 20 minutes later, and then now we have a STEMI. So it doesn't declare itself all the time just by talking to the patient. So therefore, there had to be a way, let's say a biomarker or a test that we have to check to see if someone is having a heart attack or not. And hence the discovery of troponins. Troponins are part of the structure of the heart muscle cell, the myofibrillar structure. All the troponins you hear about, troponin I, troponin T, C, these are all just pieces of protein inside the heart muscle cell. And it's exclusive there. So what makes it perfect biomarker to detect myocardial infarction, because If you find it in the bloodstream, then the integrity of this myocardial cell is disrupted. In this myocardial cell necrosis, by definition, you have MI. So that's what makes it a good cardiac biomarker. It's exclusive to the heart muscle cell, and we've been trying to get better and better in detecting the slightest amounts of, or the smallest amounts of troponin in the bloodstream, just to detect these myocardial infarctions early on. And now we have the high sensitivity troponins. So you can imagine if you have a myocardial injury of any sort, it's going to lead to elevated troponins. So how are we going to distinguish if this is an acute coronary syndrome versus something else? Hence the universal definition for myocardial infarction. There are different types of myocardial infarction because, again, once you're troponin positive, you're MI. So the only question is which one you belong to. Is it type 1, our interest, patients that come with plaque rupture? Is it type 2, which we see a lot, and we'll talk about it a little bit later? Or type 4 and 5, and these are other interesting stuff. Imagine someone going for cabbage and their troponin is elevated day 2. I mean, there was a surgeon in there cutting and doing stuff, so they would be elevated troponin. When we take patients to, let's say, a stable coronary artery disease patient, I take them to the cath lab and I put in a stent. If their troponin, if they're perfectly fine and you check troponin, often you will come back positive because while we're deploying stents, we are inflating balloons, we're cutting off the blood supply even for a few seconds. So the type of myocardial infarction matters, very important. So type 2 myocardial infarction, think about it, and this is your patient with stable coronary artery disease, does have a plaque. I mean, in normal resting conditions, it's not causing a problem. The blood's still flowing okay, enough blood going to the myocardial cell, but they come in with sepsis, and then they're vasodilated all over, and their heart is beating faster because there has to be an increased cardiac output as a result of the vasodilation. So now their heart is working more. They need more blood supply, and they have a fixed supply, or actually diminished. But just this condition kind of unmasked the issue with the blockage. In normal resting condition, this amount of blood that was flowing through this stenosis was fine. Only if the heart needs more, that's when we have a problem. So would you treat this the same way you treat type 1 myocardial infarction? The answer is no, because this is a patient. Once you take them out of the hospital, their sepsis resolves, they go back to their normal condition, they're perfectly fine. They may get chest pain after they walk, let's say, 100 feet, but something on it. So when we see this, oftentimes, it's not like we're just going to overlook it, but a lot of times we see us saying, all right, well, let's do an ultrasound of the heart. If the echo's fine, then this coronary artery disease, I know there is a coronary artery disease, but I don't want to do anything for right now. I think it's fine to get this patient out and treat in the outpatient. I will investigate it more, possibly even put a stent, or this patient might need vitals at one point, but not in the hospital. So what are we looking for in terms of it? So we've seen different reasons for troponins to be elevated. With type 1 myocardial infarction, this is an acute event, and it's evolving. So you will see myocardial cell damage. The biomarker is troponin. It's going to sharply rise, and then it's going to peak. And then once your ischemia levels, like, now either this territory of heart muscle, is already, is dead. You already cut off the blood supply long enough on it, so it's dead now. And then you're going to start seeing this troponin trending down because the process has stopped with myocardial cell necrosis. So this bell-shaped curve, and it's not really a perfect bell-shaped curve, it's more of a sharp rise and then slow decline until it plateaus, is a very concerning sign for myocardial infarction. Oftentimes in type 2 MI, you have demand ischemia with the stressor on board, whether it's sepsis or whatever. You won't see, first of all, this much of troponin rise, that's one. Two, it's going to be plateau, meaning like there's nothing really active ischemia going on. It's just a demand supply issue. So EKG is already, EKG has never and will never go away for acute myocardial infarction. I mean, you can say that physical exam is just, utility with echoes and all that. But EKG is never going to go away, because the only way so far that we can tell if someone is having acute total occlusion, which is acute myocardial infarction STEMI, is the EKG. It's an EKG diagnosis. So, what we define as current of injury. And basically, an entire segment of the heart muscle doesn't get any blood supply for a certain period of time. You get a transmural ischemia. The entire muscle thickness is infarcted. And that's what's going to give you all these repolarization changes and basically an ST elevation on the EKG. In the non-ST elevation myocardial infarction setting, you can have EKG changes, but they're non-specific. You cannot rely on them in telling where the blockage is. So this is the group of patients that you want to further risk stratify. STEMI is a STEMI. They're going to go straight to the cath lab. It's the non-STEMI that you want to know who needs to go first. One could make an argument, let's take everyone to the cath lab. That's impossible. We don't have the resources to do this. No one has the resources to do this. And certainly there is, you have to prioritize things. So this is the spectrum I'm talking about. Starts with a stable angina, not our interest today. Once you have any disruption to the integrity of the plaque, we're dealing with an acute coronary syndrome. If the blockage is bad enough, you start having EKG changes, chest pain symptoms, or patient symptoms are more pronounced, and you're still not localizing, but there's still blood flow trickling in, so it's not total occlusion. And once you have a STEMI, that's a total occlusion, that's an event. Of course, that's the end of the spectrum. So to understand the therapies we apply on a daily basis, just taking for granted with this and this, heparin, aspirin, all these regimens are designed to, one, stop the propagation of the thrombus. So you already have a thrombus. You want it to not propagate. You don't want this patient to progressing and keep going on to become an NSTEMI, let's say the unstable angina and then a STEMI. So the first step in a thrombus formation is platelet aggregation. The platelets have to come in together and stick. And then that starts the cascade of coagulation, and then that starts inviting more cells in the process. And the end result of this process is these like yellow nodules here. These are fibrin. So once you have fibrin, you have a mesh that traps red blood cell, and now you have a clot that's getting bigger in size. In terms of antiplatelets, so prevent the right from the first step. So prevent these platelets from sticking together. Give aspirin, because aspirin is a class inhibitor. Thromboxane is the end result of this kind of reaction that happens inside platelets, invites more platelets, and give the patient clopidogrel or prasugrel or ticagrelor or you're blocking a receptor called the P2Y2 on the platelet. That's why we call them P2Y2 12 inhibitors. And therefore you're preventing further aggregation. And then ticagrelor, which is an IV medicine, works on a third receptor. So, and I'm sure you've had patients that come in from the cath lab, things that hasn't gone very well, or the patient very sick sometimes, we haven't got the best results. You will see the patient on aspirin, Plavix, or Brilinta, and a ticagrelor infusion. So this is a patient that you're blocking every possible receptor that is involved in platelet aggregation. And then you have the coagulation cascade, and that's what we give heparin for. Because heparin is going to intervene on the steps before you form fibrin. And fibrin is the issue, right? That's the mesh that's going to start trapping red blood cells. So you add that to the mix, then you block every possible mechanism for thrombosis. So we start with an EKG. If this is a patient has an ST elevation, then that's a patient that goes in a different accelerated track, as we all know. If it's a non-STEMI patient, then you wanna risk stratify this group. You wanna know who needs to go to the cath lab, who can go to the cath lab tomorrow. But they're all gonna get the same standard treatment: aspirin, plus minus P2Y12 inhibitor, beta blocker, nitrate, statins. Everyone's gonna get the same standard treatment. The question here that we're trying to answer: who needs the cath lab first? So we use different tools for this. You must have heard about the TIMI risk score, 14-day event rate, expectancy based on It basically depends on patient's profile, their age, their risk factors. If this is someone who had CABG or PCI in the past and coming with elevated troponin, you're certainly paying more attention to this one or more concerned about this one as compared to someone who doesn't have this history. If they have recurrent angina, that means there's ongoing ischemia. If the troponin is elevated and if it's keep rising, that means there's ongoing ischemia. And then we risk stratify them into low, intermediate, high risk. Sometimes you will see at times the low risk group, treat them with medical treatment, give them outpatient, then if they fix, we do that later. But certainly intermediate and high risk is something done in the hospital. Then this gray score that incorporates, I never use any of these two scores. But in my subconscious kind of calculation of things and thinking about the patients, I am actually thinking of all these. So the gray score, for example, involves the hemodynamics involves their examination of whether they're in heart failure or not. And if I see someone with an NSTEMI, the troponin is rising, they have history of CABG, and they go examine them, they're in heart failure, and I'm convinced that their story is, and the troponin is rising, keep rising. Well, that's a high gray score without even, getting the numbers. So timing for intervention. We found, based on studies, that if you belong to the high-risk group, you can see that if you invade, so the green line is the early invasive strategy. It makes a big, big difference in terms of cumulative hazard risk for major adverse outcomes. And that's early on in the hospitalization. Not so much for the not so high-risk groups. So it basically tells you who needs to go to the cath lab first. So what makes someone high risk? Outside of the grays, outside of 10-year score, if you have someone with dynamic EKG changes every time you do an EKG and it keeps changing, that's someone that you need to worry about. If someone is going in beta, that's someone you need to worry about. Everyone else can wait until, even for 72 hours. STEMI helps hospitals develop systems, because this is STEMI, if you have a successful STEMI, that's a system success. That's not just the operator putting the stent or the ER physician diagnosing it. It starts from the first medical contact and onwards. We know that time is muscle, so you intervene early on, you're saving more muscle, which means this patient eventually will have hopefully no impact on the rejection fraction, which dictates a lot of things with regards to their long-term outcomes and mortality and heart failure. Each 30 minutes delay increases your risk for 1 year death by 7.5%. All right, so that's why whenever this patient is identified, if they're identified in the field and there's a hospital nearby that can do a primary PCI, like most of our dignity hospitals, then they come straight to the ER cath lab. And if not, they're far out, then they get analytics. So I'm going to quickly go over two cases. This is a 55-year-old gentleman, hypertension, dyslipidemia. Someone did a CT coronary on him in 2015, had a 50% LAD stenosis. So that's this, stable plaque thing we talked about. And then he comes in with chest pain. The first stroke is 0.3, the next one is 1.6. He gets an echo. We're running out of time here. He gets an echo. I don't know, it's not playing. Hopefully this one plays. Anyways, the echo is fine. The apex wasn't moving very well though. And he has this almost 90% subtotal occluded LAD. And this is after an intervention. He was taken the same day. I was worried enough about him that I felt like he needs to go to the cath lab. This is a recent STEMI we did that was recognized for being done and properly and on time. And you could see what it takes to get a patient to have the stent and the vessel open from the first medical contact all the way to the stent, total of 77 minutes. First medical contact, this is actually outside of the hospital. That's when EMS even arrive and do an EKG. The patient had the EKG that diagnosed the STEMI at 8:52. The cath lab was activated at 9:10. Patient on the table 9:34. PCI completed. So basically the patient had a stent even before that, but PCI completed 10:06. Door to balloon time is 44 minutes.
So you mentioned that when you do in patient with STEMI, do you use when you give fibrinolytics? So how do you treat that patient once you have given? Because it's very common that we take all patients to the cath lab, but very unfamiliar with patients, especially from nursing angle, that they have a fibrinolytics. What should we do with them? The treatment-wise, like and that patient.
Correct, that's a very important question, and I can claim that I have some experience with this because I have patients transfer from the places I go to remotely. You certainly cannot be as aggressive in terms of anticoagulation, antiplatelet like someone who never received lytics. And then we certainly also have special considerations when we're in the cath lab. So this is a patient that you have lytics on board. First of all, you determine if the lytics have been successful or not. The chest pain go away, the EKG settles, and the ST elevation resolved. If it does, this patient still needs an angiogram, but not emergently. If any of these things are not there, then this is a patient that you need to take still emergently, find out what's going on. General rule, heparin is very important. Giving lytics doesn't mean that you cancel heparin. In fact, patients with lytics only have more risk for more thrombosis going on. So heparin still runs next to after lytics. And then with regards to P2Y12, we only use Plavix, and based on the age, if they're older than 75, we give them 75. If they're younger, we give them 300.
Yeah, that's a really great point you mentioned. So age cutoff is important. So 75, age 75, and greater than 75. If they're less than 75, 300. If they're greater than 75, you keep them 75. Thank you very much.